In this second part about the respiratory system anatomy, we're going to discuss the remaining parts, starting from trachea, progressing further down to bronchi and bronchial tree, and ultimately it is going to be with anatomy of the lungs. Physiology of the respiratory system would be explained in a separate recording. So if you're looking for physiology part of it, please just make sure that you go to part 3, which hasn't been yet posted, but will be coming soon to YouTube. Let's go and let's share the screen so that we know exactly what we're looking at. I would prefer that we start from this photograph, because if we go to the next slide, you would be able to see what the trachea looks like. To be honest, there isn't much impressive about it. It really looks like some kind of nice tube built by cartilages, but I prefer to start from its cross-section. Not only because I have a need to show you that this yellow-colored cartilage on this cross-section is showing that the trachea is built of stuck C-shaped cartilages, or because of its most posterior part, which is membranous, built by muscle and mucous membrane that covers it. More so to show you the relationship between the trachea and what is further posterior to it. It's the esophagus. Further posterior to esophagus would come a body or bodies of multiple vertebrae, and you'd realize that we have this situation. Esophagus, its walls could be fully collapsed. Main and simple reason for that is obvious. We do not eat 24 hours a day. We do not swallow. We have, generally speaking, a couple of meals, and here and there need to swallow perhaps a little bit of own saliva, which is produced in quite minimal amounts. However, the respiration cannot be stopped. It goes at a steady pace of 12 to 16 cycles per minute if we're at rest, and could go into 20, 30 or more respiratory cycles if we exert some physical exercise. So for that reason, it is imperative to maintain the lumen, the space of airways, free and available for fast movement of inhaled and exhaled air, where lumen of esophagus could be temporarily squished, compressed, and only would expand, and it will be done at the expense of the posterior tracheal wall while we're swallowing. And we already made it clear in the first part of anatomy of respiratory system recording. When we breathe, we cannot swallow. When we're swallowing, we're unable to breathe. So these two systems are mutually excluding each other. Therefore, this idea of esophagus getting more space at the expense of trachea is perfectly simple to understand. So what exactly do we need to know about trachea? Well, most of it, it was already said, C-shaped semi-rings stuck one on the top of another. Trachea generally extending from level of C6 vertebra, bottom level of the larynx, straight down through the superior thoracic aperture into mediastinum, and at the level of fifth thoracic vertebra, the trachea is going to split and will form right and left-sided primary or principal bronchi. Position of the trachea has to be in the midline. So any kind of medical imaging, primarily X-rays of the chest that are very commonly and typically done, if they show that trachea has been skewed to either side, basically it is the moment that cannot be omitted and recognized as something that has to be explained what is going on. Although the patient may not be showing signs of any kind of distress, trachea being displaced from mid-sagittal plane is always a sign that has to be recognized. At its bifurcation, basically this part of the trachea is named. It is called carina, and as a result of carinal appearance, the airways are now splitting into primary or principal bronchi. Keep in mind, we're talking about respiratory system, and it hasn't been used so far too frequently. We're talking about ventilation, and then we're talking about the respiration. So far, we are in a part of the system which only allows for ventilation, which is movement of fresh inhaled air in and movement of exhaled stale air out of lungs. Basically, that is the ventilation and mechanism that will allow it to happen is also part of this diagram. The principal pump, which moves air in and out of the lungs, is the diaphragm. But ventilation itself is going to reach the level of alveoli, where finally we're going to have a chance to allow movement of molecules of oxygen and carbon dioxide across very thin respiratory membrane, and that is at the level of alveolus. We have to get there, but before we reach the alveolar level, let's take a look at what's happening to primary or principal bronchi. There are two of them, one per lung, and the right-sided principal or primary bronchus appears to be a little bit wider and a little bit more steeply oriented, something that people would say looks like a direct continuation of the trachea. In a contrast to right-sided primary bronchus, the left-sided is smaller and also has the more horizontal run compared to the right-sided. The main reason for that is position of the heart and major blood vessels, which will take a little bit of space for which left lung must accommodate. And because of heart, also the left primary bronchus must have more horizontal run in order to enter the lungs. Part of the lung where principal bronchus enters it is known as the pulmonary hilus. So once the principal bronchus passes through this area called the hilus, it is not visible any longer. It runs through the pulmonary tissue, and now we can see that primary bronchi are dividing. Within the right lung, it'll have to divide into three secondary bronchi because this right lung has superior, middle, and inferior, therefore three individual lobes. Each lobe will get its own secondary bronchus. Where on the left side, situation is a little bit simpler. It is superior and inferior lobes of the left lung, therefore just two secondary bronchi will be formed within the left lung. The lung finally keeps getting into smaller, still functional segments. And at that point, although there is discrepancy of three lobes on the right and just two segments on the left, two lobes on the left, pulmonary tissue further divided into segments, basically it puts 10 segments right and 10 segments on the left, which requires that each segment get its own tertiary or segmental bronchus. This is something that we can actually see here, what is the approximate size of the tertiary bronchus, and there should be 10 of them on the right and 10 of them at the left side. What is also noticeable if you just take a closer look, going trachea, primary, secondary, tertiary bronchi, is that the amount of cartilage is gradually reducing itself. And that is correct. So this kind of rigidity and stiffness of airways gradually gives cartilage away. And from point of right or left-sided tertiary bronchi, we can now see that external appearance of a bronchus does not really show these cartilaginous beads. Truth is, more and more smooth muscle fibers will be used to build the walls of bronchi, and continuation of bronchial tree is going to require practically way less cartilage, way more smooth muscle fibers. So on the flow chart, you can see that we're having tertiary bronchi becoming bronchioli. That is not absolutely correct, but we do not have enough names. The tertiary bronchi will keep dividing at least 10, 12, 14 more times until we reach the stage of recognizing bronchioli. Bronchiolus is already something that should be practically submicroscopic structure for which we would need either microscope or some mighty magnification lenses to see them. But we're trying to really like reduce level of structures that need to be remembered. So after the tertiary bronchi, multiple divisions will follow until appearance of smaller bronchioli. And bronchioli, as they start dividing, they actually lead us to the stage of forming the terminal bronchioli. What's interesting in this section? Well, we're talking about airways, and we're talking about part of the respiratory system anatomy which allows for ventilation. Respiration has not yet been encountered, and we have to see what's going to happen to terminal bronchioli. How do we ever reach the level of alveolus? Before we do that, let's take a look at this transverse or horizontal plane section through the thorax. This is the body of the fifth vertebra, spinal cord within it, esophagus, which is definitely like pushed and squished against the spinal column. Here is the heart, also with its chambers being cut open. And here is the right-sided lung, which perfectly well accommodates to shape of the inside of the thoracic cage, and also with its medial surface that has to accommodate position of the heart. There will be a few other things that we can talk about, such as what it divides, what separates the lobes of the lung, but let's wait until we come to anatomy of the lung itself to complete it. We want to go one step further and to go from a level of terminal bronchioli. So we can see that terminal bronchiolus will keep dividing, and the byproduct of its continuous divisions appears to be respiratory bronchiolus. Why do we call it respiratory? Because here and there, sporadical presence or attachment of some alveoli on the wall of the respiratory bronchiolus is typical. However, this is just the very beginning of the respiratory cycle. So what do we have that the respiratory bronchiolus further divides into multiple alveolar ducts, and each alveolar duct will form multiple alveolar sacs. Alveolar sac is finally going to be composed of alveoli, and that is the exact moment that we've been waiting for to reach this respiratory membrane. As you can see, the cluster of alveoli that we have illustrated on this diagram is externally enriched with extreme well-developed network of alveolar capillaries or pulmonary capillaries. So through the thin wall of alveolus and even the thinner wall of alveolar capillaries, we will observe appearance of respiratory membrane, which enables movement of gases, oxygen to go into bloodstream, and carbon dioxide to be released out of it, and finally exhaled. In order to follow the exhalation pattern, we would have to start from alveolus into alveolar sac, alveolar duct, into respiratory or terminal bronchioli, and then into multiple larger bronchi, segmental bronchi, lobar bronchi, primary bronchi, back into trachea, and then up through larynx, pharynx, nasal cavity out. Let's take a quick look and let's complete this part with understanding just a little bit more as what is happening with anatomy of the lung. Obviously, inside of the lung, following the bronchial tree, reaching the level of alveoli was more valuable. And this is just external view in order for us to understand what is the lung that we can see without need of going into submicroscopic anatomy. We already know that we have right and left lungs that appear to be slightly different. I would say more asymmetrical rather than any other quantifiable measurement being applied. The right-sided looks bigger, whereas the left-sided lung, due to position of the heart, does have a little bit of a need to accommodate. The right-sided lung made of 3 lobes, and we see all 3 of them on this diagram, which illustrates the lung from the lateral side. On the left side, it is 2 lobes, superior and inferior. And right away, you can see that both right and left lung do have a deep gap which separates the lobes. On the left side lung, it's called the oblique fissure, and the same name is given to this gap that is existing on the right side. Because left lung is only made of left and superior and inferior lobe, obviously, it's the oblique fissure that separates them. But since we have superior, middle, and inferior lobe, oblique fissure first divides superior from the inferior lobe, and then it continues dividing middle from the inferior lobe. Obviously, middle and superior lobes need to be further separated, and it is done with presence of horizontal or transverse fissure. The fissures are not just superficial markings on lungs. They actually go quite deep into pulmonary tissue, and they physically divide lobes from each other. It is an important thing to notice because if the lung is affected by, let's say, something that's relatively simple, pneumonia, inflammation of the lung, we would not necessarily see the entire lung being affected by the inflammatory process. Pneumonia might be pretty much restricted to just affect a single lobe, hence the name lobar pneumonia, as opposed to entire lung being affected by it, which would be panpneumonia. So these 2 lateral view diagrams pretty nicely illustrate what left and right lungs differ from each other. They do have quite wide and flat base, which is used to station the lungs on the upper surface of the diaphragm. And being somewhat cone-shaped, left and right lungs produce the tip part or apex, which actually projects itself above the level of first rib. That's why the depression that we feel in our own body behind the clavicle is not just skin and sometimes what people believe muscular. Rather, it is a very, very close contact point with the lung and its apex. So any injuries in the supraclavicular fossa may affect also the respiratory tract quite negatively. The view that we have at the bottom of the screen is medial view, or we can also say mediastinal view, because that is the surface of the lung which is oriented towards the mediastinum. Once again, we can confirm presence of a wide, fairly flat base. Opposite to it is apex, but the entire surface of the lung, which is facing towards mediastinum or heart, appears to be a little bit more interesting for us. Not because you can still see presence of oblique or transverse fissure, but because of something else. At the mediastinal lung surface, we have this area which is known as the hilus of the lung. So all the structures that are passing through the hilus actually form the root of the lung. And sometimes people have difficulties just understanding the difference between the hilus and the root. If you think about just planting a tree in your backyard, basically there will be a patch of soil which you need to dig. That's the hilus. And then what you're going to plant into it is a tree which practically has its roots going deep into soil, and the main trunk of a tree that keeps growing out of soil. So the tree itself becomes the root, and area into which you planted is the hilus. Obviously, multiple structures run through the hilus. Some of them on this diagram are colored blue, red, and some kind of brownish shade. So let's clarify. The uppermost position of the hilus, although it is colored blue, are branches of the pulmonary artery. Why blue color selected? Because pulmonary artery brings blood away from the lung, that is qualifying it to become an artery. Blood is moved away from the heart. And content this time is carbon dioxide rich blood that needs to enter the lung and go through the process of reoxygenation. Therefore, blood vessels that are coming out of lungs at the lower part of the hilum, they carry oxygenated blood, and their names are pulmonary veins. In between them, of course, the remaining part is something that we recognize and immediately can backtrack to say that is primary bronchus that enters the lung also at the hilum. Because a lung is very much like a sponge, any kind of solid structure that sits nearby will likely to leave a fairly deep impression that is going to be obvious, as one can see here on the right lung. We have impression, which is generated by spinal column, whereas on the left lung, we have this impression generated by aorta and subclavian artery that is taking away from aorta. This is aortic arch impression. And if we go further down, it is going to be cardiac impression. Cardiac impression is much more visible. If we take a look at the lungs from anterior direction, you can see it here. And this is what is the cardiac notch for the left lung. Cardiac depression is present on both right and left, but cardiac notch is what we see here on the left-sided lung. This segment of the pulmonary tissue very close to its base is called the lingula, which means a little tongue. A lingula in its size and position is variable from person to person, sometimes very small and irremarkable, sometimes much larger than the one illustrated. And of course, it can significantly overlap the anterior surface of the heart. That is one of the reasons when the auscultation of the heart is done, we instruct our patients to temporarily stop breathing so that the respiratory sounds do not interfere with the sounds that are produced by cardiac valves. And as a result of this, lingula is very much unknown how small or how big it is, but because it could project itself over the heart surface, might become a little bit more of a problem for auscultation. So for that reason, please can you just take a breath, do not breathe until I tell you so, and then you can do auscultation of the heart if that action needs to be done. Finally, to complete this part of the respiratory system anatomy, we're going to just very briefly go to the level of alveolus surrounded by multiple capillaries. Basically, we have two types of alveolar cells. Type 1, which forms the alveolar wall, and as you can see, practically it extends throughout the alveolus. Together with the capillary wall, it becomes part of the respiratory membrane. Also, very important cells that we need to recognize are type 2 cells. They produce and release into alveolus surfactant, a substance which is reducing the surface tension. In other words, to make it very simple, it is preventing alveoli from collapsing while we're exhaling and moving air out of its lumen. Surfactant practically keeps alveolus as some kind of loosely inflated bubble or balloon, and as such, alveolus does not offer any additional resistance to air that moves in and brings that much needed oxygen. Certainly, it would be very unfair to go away from this diagram and not to mention mobile alveolar macrophage cells, because regardless of how well the system that protects the respiratory tract is made, some microparticles of dirt could still reach the level of alveolus. And of course, it would be a very detrimental moment for us if they are allowed to accumulate. Any foreign material, including some of the dead alveolar type 2 cells, are going to be removed by alveolar mobile macrophage cells, which ensures that longevity and quality of work given to lungs is something that we can carefully monitor and maintain. The next part will be about physiology of the respiratory system. We need to complete anatomy as some kind of connecting point just by using this diagram that illustrates number of different structures that are attached to the walls of the thoracic cage. On the right hand side, you can see spinal column with 12 pairs of ribs attached to it, and the sternum, which serves as the attachment point for upper 7 ribs or true ribs. Of course, being part of the skeleton, regardless of all the different joints that are formed between spine, ribs, and sternum, it would be quite stationary unless we would have a number of different muscles that are attached to the skeletal features of the thorax. So some of the muscles are going to be moving ribs upward, like external intercostals. As the ribs move outward, that would be shaded gray part of this diagram, the thoracic cage will expand and it will result in our ability to inhale, to bring air in. With internal and innermost intercostals that will depress ribs down, they would bring the thoracic cage back to its original size, and that's going to be needed during exhalation or expiration. However, this is just to justify what do we see on this diagram. On the right-hand side, position of the diaphragm has been noted, but it is not really like completely illustrating the diaphragm. The diaphragm is the principal muscle of respiration. With its contraction, the diaphragm will descend down into the direction of abdominal cavity. It will, for that reason, increase the volume of the thoracic cavity and will decrease the pressure so that we generate pressure gradient that is higher in the air that surrounds us versus lower pressure that is within the thoracic cage. As a result of pressure gradient, air, of course, moves in. During the second half of the same cycle, diaphragm will relax and will start gradually elevating itself up into thoracic cage. As a result of that, basically, the volume of the thoracic cage will start reducing. Intrathoracic pressure will first equalize and then become greater than the pressure of air that surrounds us, forcing this gradient as momentum for us to exhale all stale air. The diaphragm, being the principal muscle of respiration, is going to be greatly assisted by a number of different muscles that are attached to the ribs, and they're called accessory muscles of either inhalation or exhalation, depending what kind of action they would exercise on the ribs. As you can see on the left side of the screen, sternocleidomastoid scalene muscles attached to ribs 1 and 2, sternocleidomastoid attached to the clavicle will elevate the upper part of the thorax. together with external intercostals, which will elevate ribs. Of course, these muscles all help us to inhale. Abdominal wall muscles, um, internal and innermost intercostals, are going to have the opposite action. They will depress the rib, and they would be seen as accessory muscles of exhalation. Finally, if you wonder what this bucket at the bottom of the screen really wants to show, it is just for illustration purposes, because we frequently see in anatomy that movement of a rib as part of the thoracic cage is something that we compare to movement of a bucket handle. Bucket handle, as you can see or know it, is attached at two different points on the bucket. And of course, then if we play with a bucket handle, we know how easily we can force it to go one side or the other side of bucket. Of course, just if we apply a little bit of movement, lifting it up and letting it drop down, that is exactly the type of movement which we need you to understand to be able to practically apply this bucket handle movement as something that very importantly is driving the process of inhalation and exhalation. So we will continue with physiology of the respiratory system. For now, we can say that the most important anatomical elements have been added and they should be now in place. So third part will be discussing the respiratory system physiology, as well as a couple of interesting clinically relevant points that we would try to make if something happens and the respiratory system is not necessarily functioning at its best. So this is the end of part 2. Part 3 will be coming soon on my YouTube channel. Thank you for watching it. Please follow me on the YouTube, and if you leave a nice comment, I would definitely be very, very appreciative of that. Thank you.